You know, for the last number of years, we used to have as our last speaker Jim Baumgartner, who was with the Congressional Budget Office. But Jim retired last year, and so we've had to search and found an expert to replace him. And Bill Hoagland has a distinguished career in health policy and budgeting and finance. He is currently with the Bipartisan Policy Center, and he helps manage fiscal, health, and economic policy analyses for his new center. Before coming to the Bipartisan Policy Center, he was at Cigna, where he was doing health policy work at the federal and state level for Cigna. But prior to joining Cigna, he spent the last 33 years working for the federal government in various budget positions. He was on the Senate Finance Committee, the U.S. Senate. He was working in the office of Majority Leader Senator Bill Frist when he was the Majority Leader. He's been involved in looking at the fiscal impact of major legislation, and he received an award, a Distinguished Service Award on budgeting from the Hill. So he's got an extensive resume. I won't go through it, but please look at it. So please join me in welcoming Bill Hoagland. Thank you.
Good morning, and thank you, Paul and Dr. Felton. I do have one of your books on my shelf thank you, Margaret. Thank you for inviting me to, this is my first conference here. And I see the clock ticking away, so I have to go quickly. I am a budgeteer, so I do have a few slides that I want to work through. And just one small correction, Paul, only the legislative types would know this. There is a major difference between the Senate Finance Committee and the Senate Budget Committee. I worked on the Senate Budget Committee for all those years. They would not like that. First, let me begin by saying that in 1922, the Nobel laureate in physics, Niels Bohr, famously said that prediction is very difficult, especially if it is about the future. And of course, that great philosopher Yogi Berra followed up a few years later saying the same thing. This is a forecast conference, and a prediction about health care. And let's be honest, we are in the midst of, as already been mentioned, one of the most exciting, dynamic, and even scary times for Americans in the healthcare system this is a period that most of us have never experienced in our lifetime. Predictions about the future are difficult, particularly about healthcare, and I'll demonstrate that in a minute here with a couple of slides. First of all, let me just back up, who we are, just to put it in quick perspective. If you can believe it, Bipartisan Policy Center in Washington, D.C. these days, but it was founded by 4 Senate Majority Leaders in 2007. It's a 501c3. They cover a number of policy areas, and as has already been mentioned, my role is to oversee the economic, health, and related projects. We prefer to think of ourselves as a do tank instead of a think tank, because whatever we come up with in terms of these bipartisan recommendations, we do have a 501c4 operation that actually carries those out. I was asked this morning to just cover quickly the outlook trends for the federal health care budget with a focus on Medicare and Medicaid and the challenges going forward. Let me just say that I'm going to kind of repeat a little bit of what Mr. Glassman has already mentioned in terms of the deficit and budget, but there are 4 areas I want to cover real quickly with you this morning. The federal budget outlook, an outlook on healthcare spending going forward, a general comment about healthcare reform, and finally, the challenges going forward for healthcare in this politically charged year. First of all, I know, as Mr. Glassman has said, the federal budget debt and deficits are not the hot topic they once were, particularly when you listen carefully to what the presidential candidates are saying. But maybe I can convince you that still a major issue, particularly the structural deficit. I had prepared these slides before the president released his budget projections last week, and this presentation will be based primarily upon the most recent CBO current projections, and indeed that was where I began my career in Washington with the first director of the Congressional Budget Office, Dr. Alster, who is now another boss of mine back at the end here at the Bipartisan Policy Center. But I can tell you that the President's baseline estimates, and we refer to them as baselines, but this big bird on automatic pilot, where is it going? I can tell you that we're all in the same basic direction as it relates to increasing federal debt and deficits. You'll see the red line there is increasing deficits. I always like to point out the last time we actually worked to surplus was the last time I worked on Capita. No, that's not true. Go forward. Let me put this into a little bit, a lot of numbers here. What is most important in this slide is the summation of the current law of federal spending, revenues, debt, is the steady increase in the debt held by the public. From a historic high that we're at today, close to 70%. As you can see, going on out under just modest projections here, economic growth, Mr. Glassman, a real 2.1% over this period of time. We're still looking at a growth in debt held by the public, close to 90%. And I have to remind everybody that, thank you very much, investors from overseas, about 60% of that debt is not owned by Americans, but is owned by, thank you, investors from overseas. We are, as Rudy Penner likes to say, the best-looking horse in the glue factory. And as it relates to breakdown of federal spending 10 years from now, health care, Social Security, national security, and interest on the public debt will consume over 3/4 of all federal spending. One might conclude that your federal government is a very large insurance company with a security force. And going forward, federal spending for health care programs and Social Security will even squeeze out our spending for national security. And I should note that these are current, what we call current law estimates. The President's budget last week proposed major savings, again, in particularly Medicare, particularly in the Medicare Advantage programs, Medicare prescription drug payments, adjustments for post-acute care providers, and increases in Part B and Part D premiums. You have a panel coming up who will tell you about whether or not any of that's going to actually happen. In total, the President's estimated his budget last week that there would be over $400 billion in savings taken out of the Medicare program over the next 10 years. And even with those savings, the President's budget will still grow annually at close to 5.8% over the next decade. And I should offset this by saying that these savings in Medicare are offset by the President's budget to increase spending in the Medicaid budget by nearly $30 billion. Let me just say that, please note, if there's one scary chart I can put up, it is this one. I'm not making these numbers up. Medicare is not the fastest growing component of the federal spending. The fastest growing, it won't be Medicare, it won't be Medicaid, it won't be Social Security, but over the next decade, the fastest growing component of the federal budget will just simply be paying the interest, the annual interest payment on that accumulated debt, assuming that, in fairness, assuming that interest rates do click back up into the normalized rate of 4%. Okay, shifting to the outlook for healthcare spending. I'm going to return to the theme of how difficult projections are into the future as we look for it. Let me observe that, and I messed up this morning, I'm talking to Mr. Glassman, but there was a book that a friend of mine, Kevin Hassert, co-authored with Mr. James K. Glassman in 1999 that was entitled Dow at 36,000. And I think the best we've ever reached was 18. I apologize to Mr. Glassman. I was going to rub it in, but he's James E. Glassman. But Mr. Glassman's projections, James K. Glassman's, are not the only ones that have missed the mark. A little difficult chart to read, but post-ACA, in January 2011, after the Affordable Care Act, 5 years ago, the Congressional Budget Office, my old alumni, I'm an alumni, I admit, projected that the federal spending for the major health care programs would total over $1.1 trillion in 2015, last year. Actual spending came in well below that. at about $100 billion in that year, 6% lower than what was estimated just 5 years earlier. More importantly, I know this is a projection at least as of today, if you go out back in 2011 for the 10-year projections at that time to 2021, based on the latest estimates from this Congressional Budget Office last week, nearly 18% for Medicaid and 11% for Medicare are still lower by the year 2021. We certainly overestimate. This is a little unfair. It's unfair to CBO. It's unfair to Mr. Glassman. Back in 2011, since how were they to know that the Supreme Court would rule 1 year later that states would not be required to expand Medicaid coverage under the ACA, or the many other regulatory and administrative rulings that have transpired? But the simple point I am trying to make is that estimating federal health care expenditures is a very precarious business in today's rapidly changing health care sector, overlaid with a very volatile political environment. But Winston Churchill observed that the further back you look, the further ahead one can see. So looking back to 2014, the actual total national health care expenditures in this country were about $3 trillion, and that was a 5.3% increase over 2013. You've heard this number before, 17.5% of our GDP, the highest of any of the industrialized countries in the world. And we do have, however, a private public health care system. Government at all levels funds nearly 45% of all health care spending, and the private sector funds about 55%. And within that $3 trillion figure, we are reminded that the Institute of Medicine not too long ago estimated a quarter of that health care spending was unnecessary and wasteful. How to remove this unnecessary spending while minimizing the impact on patient access and local jobs clearly remains a challenge. Now, let's focus just for a second on the public sector, Medicare and Medicaid. Total expenditures for Medicare and Medicaid grew faster than the private sector in 2014, and similarly over the last 5 years. What is interesting and challenging to us budgeteers is the simple fact that on a per capita basis, growth in these major public programs has been less than that in the private health insurance sector. And note that even in the Medicaid area, and it's a little unfair again because of the growth in coverage, but per capita spending on Medicaid in this country actually declined 2% between 2013 and 2014. There was a 4.5% growth in per capita health care expenditures between 2013 and 2014, but it was not driven, as one might think, by age or medical prices, but nearly half of the growth was simply due to increased use and intensity of services, particularly for hospital care, physician, and clinical services and prescription drugs. The problem going forward is simply that added to the increased use and intensity of healthcare services, the capitas will also increase due to an aging population, has been mentioned in Medicare, and explicit policy and an explicit government policy right now to expand access to low-income families in the Medicaid program. I would just point out that between now and 2026, the Medicare population will grow 60% over what it was in 2010, 35%, 40% over what it was last year. The results going forward are the facts that are driving the budget numbers I outlined earlier, with annual growth rates in the Medicare program of 6.5%, Medicaid at 5.5%, and particularly, and again, it's starting from a low base, I understand, but the growth in health care subsidies through the Affordable Care all exceed the growth in the economy over the next decade. To me, the one startling number in this chart up here is the fact by 2026, nearly 70%, 68% there, I believe, 68%, all federal mandatory spending will fall in the healthcare sector, a government that is a health insurance company with a small security force. Let me, beyond the long-term numbers, what are the issues going forward? In preparing this for this conference, I pulled out an old journal. Joe Antos heard about this earlier this week. I apologize, Joe, and I see Jim Capita saw this also. But it's an old journal. Some of you are in this, Professor, you probably remember this, the Annals, the old pink Annals. And in January of 1972, nearly 45 years ago, and there's an article, the whole journal was devoted to healthcare, the nation's healthcare, some issues. And an article by Ann Sommers from Princeton on issues of the future. Remember, 45 years ago. She listed 9 items. Number 1, consumer lifestyle. Number 2, availability of 24-hour comprehensive care, access. Number 3, rationalization of the delivery system. Number 4, definition of professional rules to assure personalized care, workforce. Number 5, free choice. Number 6, quality controls. Number 7, cost controls. Number 8, long-range financing. Number 9, long-term care for the aged. 40, almost 50 years ago. 50 years ago. Sometimes analysts can forecast future health issues. Professor Sommers' list has not changed from my perspective after nearly half a decade. Time limits me to discuss the 9, except one ongoing overriding issue captures many of the 9. How, under these budgetary and cost constraints, can care be delivered efficiently, effectively, and rationally? The key goal of delivery system reforms, from my perspective, is to alter the traditional fee-for-service payment system into one that rewards quality and value over volume. The old models of care delivery have been turned on their head, and they are being forced to change by the Affordable Care Act and legislation and regulation that were issued a year ago. In January 2015, the administration announced a goal of tying 30% of Medicare payments to quality and value, and by the end of 2018, 50% of the deliveries to be based upon quality. Just last week, the president's budget said it was on track to meet the 30% goal by the end of this year, while hospitals have been subject to performance-based payment provisions of the ACA. The enactment last year about this time of what was called the Medicare Access and Chip Reauthorization Act, MACRA, to fix the doc fix, now brings physicians into the models of performance payments in 2017. And just on Tuesday of this week, CMS and AHIP released 7 sets of clinical quality measures to simplify and streamline what is a terribly confusing and administrative nightmare of over 1,400 different quality measures out there. In 2016, I think, will be a critical year for physicians to learn about the details of MACRA and the implications for their practices. It has been and will be very disruptive to physicians who see such policies as interfering with their delivery of care. My sense is that under this new law, there will lead to at least an uptick for some who will just simply, older physicians particularly, who will just simply say the heck with it and retire, and others joining or affiliating with health systems that already have experience in managing performance-based payments. The transition to the delivery system will be disruptive to some, but also create great opportunities for others. And this transition will also further expand the spread of ACOs going forward, models for the future of Medicare delivery. The most recent data estimate that there are nearly 24 million individuals who are receiving care from 744 of these so-called ACOs or delivery systems, Of this total, approximately 9 million receive care from 426 Medicare ACO programs. Simple math would suggest that the majority of ACO's volume is coming from the commercial and Medicaid sectors. Today, it is estimated nearly 70% of the U.S. population now live in localities served by ACOs, and that will grow to 80% by the end of the decade. It is clear that the Health and Human Services' recent announcement of that 50% goal of Medicare payments to alternative payment models, coupled with the continuing endorsement of the approach from state Medicaid programs and commercial interest, that the support for this new delivery system will continue, and I believe California is the lead in the number of ACOs that have been created. Well, knowing that I am going to trespass a little bit on the next panel session, let me simply close out by stating the obvious. The direction of healthcare policy and therefore expenditures is and will be impacted by a very volatile political environment. No question about it. The country remains divided on their views of the ACA going forward. It hasn't changed that much since the enactment of this law. It remains a very controversial, if you ask that particular question, going forward. And more importantly, the division is most pronounced by political party affiliation. Huge differences here, as you can see, between Democrats, Republicans, and only independents that are in the middle, which then finally is reflected in a Congress that has, at this particular point, the highest level of party polarization since data has been kept, and will be reflected. Just let me highlight, having been an old Senate staffer for many years, we hear a lot about the presidential election, but look at the number, of course, all the House members are up this year, but look at the Senate. For those who are up, it's almost an identical switch of what it was in 2014. 24 Republicans up and only 10 Democrats. At the margin, this is going to be a very, very tight Senate coming out. I can't predict, nobody can predict, but I can predict one thing. There will not be a 60-vote majority in the United States Senate for anything. If you think we have stalemate now, it's not necessarily going to get any better. And I hate to raise this, but go out to 2018. Look, it flips again. This is a roller coaster we're on. Let me close by saying I know Norm Ornstein is going to speak to you at noon. And while the book he and Tom Mann wrote a few years ago entitled "It's Even Worse Than It Looks," with respect to Norm, up this final slide, it could be worse. As a young Senate staffer with Mr. Capita back there, we were often shown a desk on the Senate floor that with hash marks visible on all sides of it. The incident that occasioned that historic event is depicted in this slide. It was 1856. Congressman Preston Brooks, a Democrat from South Carolina, came across the Capitol Rotunda onto the Senate floor and viciously caned Senator Charles Sumner, a Republican from Massachusetts. Probably need not tell this audience what precipitated the attack in 1856, but Senator Sumner, an anti-slavery abolitionist, had given a speech the day before that offended the representative's uncle, also a senator from South Carolina. Senator Sumner remained in a coma for nearly 2 years, and that hacked-up desk remained unoccupied throughout, which is still visible on the Senate floor today. That attack has been considered by historians as symbolic of the breakdown of, quote, reasoned discourse. Reasoned discourse. That, of course, led to our Civil War. It could be worse, Norm. At least we do not have canings on the Senate floor, to my knowledge. And while at times one might wonder if civil discourse is a lost art in our political system today, I guess I'm Midwesterner. I am a farm boy from Indiana. I remain optimistic that not only in the healthcare debate, but as well in other policy areas, civil debate will prevail. After all, it is essential if we are to preserve the democracy we all cherish. Thank you.
Okay, now we have time for questions. And before you, when you raise your hand, somebody has a cordless mic on each side of the aisle. So raise your hand and somebody will pass the mic to you. Okay. As we get started, I was going to ask Jim Glassman, what do you see as the major risks to your scenario for going forward?
Yeah, I think for all of us who have a sense of our history, the thing that would worry me the most would be if we wake up one day and we realize that we're really much more stretched than we think, and we have more inflation problems than we think, because that is a nightmare scenario. That would mean the Fed has got to do something more with interest rates. It would an increase, a normalization of interest rates would expose the imbalance that's brewing in our fiscal situation. But honestly, it's very hard for people to believe that this is a big threat. So I think for now, this is not our biggest problem. I think if you go back, if you go back 7 years ago and you'd asked, will we worry if we have to worry about the European Union blowing up? If we have fiscal disarray in Washington and the government shuts down and rating agency downgrades U.S. debt for the first time in history, and you have shocks to the U.S. economy that throw some industries off, others off, you would have said, at the time you would have said, those sound scary, but they haven't been. And I think the reason is because when you're in a recovery, we do a pretty good job of getting back on our feet. And it's because our business sector, the survivors see opportunities, they take advantage of those opportunities, and we don't have an inflation issue, and it allows the Fed to be supportive. You don't worry as much about things that could derail you. So I think, to be a little shallow about it, what I'll say to people is the main thing I worry about right now is a meteor strike, because that would be bad. That would be bad.
That's good. That's good. Thank you. Okay, somebody here. Cindy.
Good morning, Cindy Enos. Okay. CoPal Solutions. And Jim, I just wanted to ask you about the impact, the potential impact of so many people hitting retirement age with, I think the figures are like 30% of people don't have either a pension or retirement savings, and about 50% of them only have a retirement account. My sense is that would really create a big drag on the economy, as such a big swath of people have such limited income to spend. So I just thought I'd ask you about that.
Part of this is if you watch what people are doing after 50, what you're watching is people staying on the job longer. They're doing, because life expectancy is rising, the reality is changing. So to some extent, that's been tempering this demographic thing. But I'm sure it's a big problem for a lot of people. I don't know if it's worse than it ever is. The problem is there's a lot of people who are never really well prepared for retirement. We're probably better prepared today than they were in the 1920s or earlier generations. So I think there's a lot of divide going on, because if you look at household net worth, so count the real estate that we own and the equity, it's at all-time record highs. But that's not a story about everybody. That's a story, wealth is highly concentrated. Real estate, 2/3 of us own our home, so it tempers it a little bit. But I think it is a big challenge. It's probably one of the reasons why you're seeing older faces at Starbucks and all these places. When you look around the country, the population does look like it's aging. So it's a challenge, but I don't know. Fortunately, we have more safety nets than we used to, so that helps a little. But yeah, I think, honestly, I think the bigger challenge, I feel worse for people who, you lose a job when you're 50, it's very tough to retrain quickly. People who are retiring now have had a whole lifetime to be prepared for this, and they, you know, I'm more worried about people who are just in the middle of life and young people coming out who find that there aren't as many opportunities unless they've got the skills. That's the bigger challenge to me.
Okay, sure.
Could I take this as an opportunity to plug my organization? We have a Commission on Retirement Security and Personal Savings that will be coming out here in about 2 months, and we've looked at this very carefully. You're absolutely correct, but I would focus, as Jim did, on not the ones near retirement, but the ones that the younger population, because what we have found is that the availability and access to a retirement plan, particularly for small businesses, is 50% of those individuals that work in small business do not have access to, and the complications of that. So one of the recommendations that we would come out is how to simplify that to make it more easier for individuals and companies and businesses to unite in terms of some nexus to be able to offer these retirement plans that they're not offering today for that working population.
Dr. McDonald from Tremont, Illinois. Because the deficit is not cyclic, but is structural, Grover Norquist has so many legislators who will not allow to pay for promises given with taxes. He's basically put the deficit in a subprime rate. What is going to be the solution? How are we going to pay and get around Grover?
Well,
Grover, I won't say he's my friend, and I'll get in trouble. I work for Republicans. I don't think there's a solution to the structural deficit problem here that doesn't include both changes to the tax code, number one, that simplifies it, makes it more growth-oriented, but also, don't kill me, Joe, raises revenues. I don't think we can do it. I think it's a combination of both controlling spending going forward, and that means giving up on some of the proposals the president has in his budget, I will say, are good. A lot of you are not going to like it, but it's going to require reductions in spending and increases in revenues. Gene Sperling wrote a book a few years ago, which I think probably gets to your point. Never in the course of human history has dead men and previous legislators had such an impact upon our fiscal policy going forward. These programs were put in place with the assumption that we were going to always have 4% real growth or something like that. It won't work. I'm not happy to bring that message to you, but I do work for a bipartisan policy center, and I don't think you can do this and address the structural deficit without both revenues and spending reductions.
yes, right here.
By the way, you know, what's going on in the auto industry and the UAW gives you a little taste of how you go about these things. This is not a problem just the federal sector has been dealing with. Things got out of line in the auto industry, and watching how things are playing there, I'm seeing the same story play out in the state and local government sector, because my daughter is a social worker at school. I know this story that's playing out. What's happening is things got out of balance, and so what are they doing? They're asking, there's two-tier pay structures. They're offering lesser pay to new people coming in. That's maybe a humane way to do this, because if you're 55 and retiring, how can you deal when they change the rules of the game? The problem is you're creating a tension within the system, and so in the UAW, they really fear that when the younger workers get more and more voting power, they fear that they're going to be voting the powers away. But what we're seeing in the school systems and everywhere, The new teachers are being paid less, and the pension benefits are less generous, and that's the reality. You've got to tighten your belt, and the problem is it's happening because the taxpayer doesn't want to carry a bigger burden. So I don't know. I get the feeling from the American electorate that we're not in the mood to be carrying a bigger tax burden. So that's going to force the issue on the spending side.
Question for Mr. Glassman?
Go ahead.
Sorry.
We can raise revenues without raising taxes by simply hiring more people in the IRS. And we're talking about hundreds of billions of dollars each year.
And
That sounds like the
I'll just simply say that, and that's the sector of the federal budget in terms of the administrative portion of the budget that is being squeezed by the other, what we call, I'm getting the budgetees here, the discretionary portion of the budget. That's the area most of us think of as when we think of government. That's TSA, that's your post office, that's your highways, that's your research. Those are the areas where these other programs that we have made commitments to that we can't live up to are squeezing it so that there's no money to pay for doing what you want to do.
I just wonder how many people are hiring more in the IRS? Thank you, John. Okay.
Question for Mr. Glassman. Going back to your comment about the Gini coefficient and the impacts of inflation on low-income people, what is your views on the minimum wage and the prospects to raise minimum wages? California currently has a governor who's going to be, running for that.
I side with my friend at the Fed, Bill Washer, who's on the side of our profession that says minimum wage is not the most constructive way to go about this. Here's the problem we have. I mean, minimum wage jobs are starter jobs. They're ways to get people into the job market, and we hope they don't aspire to have a minimum wage job forever. It's sort of a starter job. So if you make it more expensive for businesses to have minimum wage workers, those starter jobs, you may be helping the people right now who have the job, but you're really cutting out opportunities for the next generation, the generation after that, to get started in life. Those of us on this side of the debate think that the smarter way to go is use the earned income tax credit to help people who are low income, but don't make it more difficult for businesses to hire people. And you might think, well, minimum wage jobs, there aren't many options for businesses. I remember 10 years ago, I think it was, McDonald's was experimenting with something. You drive in to place your order for the hamburger and whatever, and the voice you hear is not coming from inside. It's coming from India. And then you drive up to the window, and there's fewer people inside working, running things around. And that's just a reminder that even in something as simple as quick service industry, people have options, and there are ways they will, if they have to, and people aren't willing to pay more for the products and the services you're getting, they're going to force businesses to do things to create fewer opportunities. So young kids, teenagers, it's amazing. The participation of teenagers in our workforce has really been declining dramatically. Well, part of the reason is because when we all go get gas, unless you're in a right to drive state like New Jersey, you pump your own gas. That used to be jobs that teenagers did, and it's just a reminder that there's a whole world of jobs out there that are low-skilled jobs, and we really need to think of them as opportunities for getting people into the workforce, learning how to set the alarm in the morning and get up to work and go to the work the same day, every way. And it takes, you don't want to cut that opportunity out for people. That's the problem with the minimum wage.
John?
Let me just note from the other side. First of all, the minimum wage today is, I'm going to get these, just estimate, basically it's about 30 or 40% lower than it was in 1967. Now, if we're supposed to be paid for our productivity, could the productivity of these minimum wage workers really be lower than it was in 1965, 1967? Another point I want to make, when you raise the minimum wage, it's not just, there's offsets, and the offsets are that you have less turnover and you have less training cost. So I'm not going to make the argument that you can raise it infinitely, but I'm saying within some margin, I believe you can raise it. And if we look at the cities who raise the minimum wage, like Seattle, and I think there's a long literature on minimum wage, but the ones which tend to have control groups tend to have much more positive results on the effects of minimum wage.
We do have an expert at the University of California, Irvine Economics Department who's written a great deal on the minimum wage, David Newmark, and I think he would disagree with that last statement.
See, I think we would be better off smarter. You help so many more people if you would take that energy and that money and put it into job training programs. There's so many opportunities out there that I hear about all the time from our clients because the world has changed and technology, jobs require more skills. I think we'd be so much better off to give people skills for better jobs rather than try to force somebody to pay you more for the same skill. If the market's going to bear it, fine. But there's so much that can be done to help people do better by putting shop class back in high school and creating more cooperation between the community colleges and businesses and those kinds of training programs.
Okay, another question. I think there's a question up there.
My name is Peter Beerhouse. I'm from Montana, and I want to continue with the jobs piece. If I understand Mr. Hoagland, it looks like 68% of all federal spending will soon go into health-related categories. And that suggests to me much of our labor force will be in healthcare. So I'm curious about, is this the most productive sector to put society's labor force in healthcare? That's sort of one question. And the second question, I'm just curious, what would you say is the forecast for future incomes in healthcare, particularly physicians and nurses?
You want to try it, Bill?
A very, very, very good question. My quick response is, and let the experts here respond better than I'm sure. I think the workforce in the healthcare sector is going to dramatically change. And I think it's going to change away from the traditional physician toward support, nurses, nurse practitioner, all the ancillary. I think that's the way. And I think that's not bad in the sense that if that creates more efficiency and better quality, and maybe leaves more time at the end for the physician themselves to have more time with the patient, that is positive, I think, long term. Clearly, the fastest growing component, I still think, of the workforce going forward will be healthcare. It is simply because of the demographics we discussed. There will be demand for these kinds of jobs out there, and so I think it's going to continue to grow. But I do think there is inefficiencies in the delivery system that maybe through a reorganization of the workforce structure, we can squeeze out some of those inefficiencies with that triple aim goal of reducing cost and increasing quality and improving access. I think it's there. It's just going to take time.
Does anybody else want to comment? No. Thank you. Another question? Oh, there's one over there.
Question, please. We've been talking about the American system here, expounding on both the questions of the extreme cost of healthcare delivery as well as the job components in America. Could you comment on how we compare to the rest of the world? We hear about socialist medicine, we hear about Canadian and English healthcare systems. Where do we stand relative to that? I'm aware of statistics where we are the most expensive healthcare in the world, yet we fall, I believe, 36th in the world in healthcare delivery, just behind Ecuador, just in front of Cuba. So where are we? What's our report card relative to the rest of the world?
Well, we certainly are the most expensive in the world. And on quality of care, I know there's different measures, and it's very controversial, and I'm certainly not an expert, I'm a consumer. But I would say that we tend to fall in the middle of the pack in quality of care measurements. Now, with regard to life expectancy, we look very bad. But that may be as much determined by factors outside of the healthcare sector as within the healthcare sector. Certainly to the north, Canada has a higher life expectancy than we do. Infant mortality in this country is very high. But again, a lot of that is attributable to the fact that we still have many uninsured people.
You have a lot of experts here that probably know this better. I'm speaking as an outsider. My impression is that we spend a lot more in healthcare than Europeans do. And what's interesting is if you look at why that is, it seems to be concentrated in end-of-life issues.
I would say that the reason we're more expensive, there's an article, It's the Price Stupid, the most well-read article in Health Affairs. Our prices are higher, our wages are higher, our physicians are paid much more than in other countries. Our administrative expenses are much higher. I think our use of services is not higher. If anything, it's lower. Certainly in hospital days, we tend to be low.
Ted?
I heard accountable care organizations mentioned, and Clayton Christensen, the inventor of the term disruptive innovation, wrote a piece in the Wall Street Journal that the only party not accountable in that multi-party transaction is the patient. Can you comment on that?
My understanding that a number of the provisions that it relates to the quality control we talked about at the outset here is a move toward greater responsibility for the individual to take on more responsibility, more personal responsibility. Now, the problem with that is what you see here in his charts is that means a higher deductible, and then that makes them pay. But I truly do believe that some of those new accounting or the quality standards are designed to put more responsibility back with the patient. And I think we also need, quite frankly, as mentioned earlier, preventative care. We need to focus more on some of the, I don't know if these statistics are right, but I've seen numbers. My old boss, Dr. Bill Frist, likes to say that 70 to 80% of all healthcare out there has nothing to do with the healthcare system itself. It all has to do with social determinants of health, that having to do with lifestyles, that having to do with nutrition, that having to do with exercise. A lot of this stuff is stuff that we as future patients have to take on more personal responsibility. How do you force that? You force that through those accountable care organizations to somehow put that burden back on the individual.
Well, I can recall when consumer-driven healthcare began, I went to so many conferences on consumer-driven healthcare. Now, the one thing I can say about these conferences, the last person you would ever see at the conference was a consumer. I mean, to say we have to be more accountable, I mean, it's almost, it's self-evident. But how to make people more accountable is very difficult. And there have been so many experiments where we have tried to do that and we have not succeeded. I evaluated an employer in the Midwest which provided information to a well-trained workforce, provided information on the price of providers, and even this group did not use that information very well. And again, from what we know about wellness programs with employers, they don't seem to pay for themselves.
Okay.
Paul?
I can't see. Any other
Paul?
comments?
Paul? Okay, thanks. I didn't know it was on. Cheryl Skolnick from Mizuho Securities USA. So, Mr. Hoagland, welcome and thank you. I guess if I may just address the issue of accountability, the only one not accountable is the patient. Yeah, you're absolutely right. That's the way the policy appears to have been designed, probably because they wanted patients to willingly participate, which seems to be a theme in the administration policy towards anything in the ACA, is give people access, let them use it, get them engaged, and we'll fix it up later, which you're seeing them do now at a much more rapid pace than whatever we've seen in the past. But my question for you, Mr. Hoagland, welcome, thank you, you did a great job. It was big shoes to fill. Thank you so much for participating this year. When you projected the classic line, the government is becoming a health insurer with a minimal security force, brilliant. Yes, that captures it. But that projection, is it based off the baseline? Does it take into account these ongoing, seemingly surprising reductions in the amount of health care that we're spending as this rapid pace of change from Medicare, from Medicaid, the move to managed Medicaid, and increasing patient responsibility across exchanges and everything else that's happening really works on utilization rates, utilization levels, and ultimately the cost of care?
I can only comment, thank you very much, and thank you for your compliments. I do think that all these projections, and they are only projections, as we said, who knows, but they are based upon fairly, as Mr. Glassman has suggested, they basically are where we are today, where we have seen a reduction in per capita cost on Medicare, Medicaid. Those are continuing on, and some of these changes, I know that it's still a controversial act, the ACA, but changes are happening out there that are reducing the per capita. And I just reemphasize what I said earlier. The problem is, that's good for right now, but it is that the capitas are growing while the per is coming down.
I know I'm one of them. I'm one of them. Thank you very much.
I'm sorry we're about out of time, but thank our panel, and you can speak to the speakers during the coffee break we're about to have. So thank you.